boy who fell off the sofa and while playing at home and came with this radiological picture.
So,
can anyone read the X-ray?
I think all of you have treated supracondylar fractures. No, anyone?
Supracondylar fracture.
What type? Gartland type? Extension type, flexion type? Extension type. And completely displaced. Okay. So what will be your management? Anyone else? Anybody for conservative? No. So type 3, Gartland, extension type, all of you will do closed reduction and K-wire fixation. Okay, any difference from that? Okay, of course, before that, confirm that there's no neurovascular deficit. Yeah. So Deepak, tell us what happened.
So does this another important, so first important point is to classify the fracture. So as we have already classified by Gartland classification, there is another important classification which I want to highlight here is different variants of supracondylar fracture and different patterns how they present. So if the standard supracondylar fracture is the one where you see a horizontal or a transverse fracture line going through the olecranon fossa, and you will be able to get it reduced by standard reduction techniques. But if you get this kind of cases like where you see a fracture line exiting obliquely laterally or a fracture line exiting obliquely medially, so these are called as medial oblique supracondylar, lateral oblique supracondylar, and the last one which you see is a high supracondylar where your fracture line is above the olecranon fossa. So you will not be able to reduce these fractures by traditional techniques what we do for a standard supracondylar, right? So very
probably more than that, your stability, if they are more oblique, then they are little more unstable, and also the pin configuration will change as per the fracture pattern. Yeah.
So this is what happened after, so it was type 3 and this is what happened after applying the slab. You can see the fracture is completely displaced now, and if we go back to the previous the injury film, you will be able to see this is not a standard supracondylar where the fracture line is going across at the superior border of the olecranon fossa, and it has a vertical limb as well. So this is unstable fracture, and then this is how it was traditionally this is what the first reduction maneuvers were looking like. So you can see there is a good valgus alignment, but still there is some instability. There is anterior.
So, Deepak, so do you think this is reduced well? I mean, before fixation, let's talk about the reduction. So
yeah, it's not reduced well.
Yeah. So you were not able to get a good stable reduction. Okay. So how many of you encounter such problems? You get your supracondylar, you do your standard maneuvers, which all of you do, but you don't, it remains unstable. Raise your hands. Yeah. So this is like very common scenario. So because sometimes as this is also even little low supracondylar, so your fragment is very small. Sometimes the swelling is so much that you're not able to get adequate flexion. So your reduction itself was not, but you still tried whether you can maneuver with a joystick and get a good reduction. So this was not acceptable.
Yeah.
So any ideas or any tricks what you do? Suppose you don't get the reduction. Anybody has any specialized techniques or anything you will try? Yes, Janki, you see supracondylar every day in, day out. So
intraoperatively I could try joysticking. If the distal fragment is big enough, I could joystick the distal fragment or the proximal.
So what do you mean by joystick? What do you do? So use a K-wire.
Use a K-wire.
To get some control over the fragment.
To control rotation of the fragment.
Okay. Or in the proximal fragment.
Or in the proximal.
Anybody else has any other ideas or have used any other ideas? Anybody will straight away go for open reduction? Raise your hands. No, so that message should go that you should have a very, very high threshold for thinking of opening. Just for not getting a reduction. So there are maneuvers which can be utilized in order to improvise your reduction. Don't just jump onto an open reduction, which was the opposite message in neck femur. If you're not getting closed, you may try and open or do again. But here, the open reduction should be the last priority. So Deepak, tell us what you did.
So we can see in the AP view the valgus alignment looks okay, but there is some gap in the fracture, and plus there is opening up of the proximal shaft. There is the shaft is externally rotated. So we have used a derotation wire. So I've just pulled back both the wires which were fixing the fracture. Just put a derotation wire in the proximal fragment, and then internally rotated the shaft, and then advanced both the wires. So this is like a small trick which you can use if there is external rotation of the proximal fragment. Just derotate and then fix the fracture like this. So this is the final fixation.
Let me ask other faculty members if they have used any other technique. There are many other techniques described. So Avi?
Joystick, you can use the K-wires just to joystick. One is this is just for the derotation. Then for the extension, either a mosquito or your suction tip, small hole, and use that to joystick and reduce, like a Kapanji type, like an intrafocal Kapanji type. So yeah, these couple of these maneuvers just to still get it enclosed.
So how many amongst the faculty actually do a reduction before scrubbing and see if it's coming? And if it does come, how many of you do a taping and then scrub it? Anyone? Or do you do a reduction again?
Once the reduction is achieved.
Do a semi-sterile something.
I think if you get it in the first shot.
You can still scrub it.
Absolutely, absolutely. So once you get a good reduction, then there is no point in leaving it and then trying to scrub it again. But there are people who would just start scrubbing and then see whichever way it is. I think it is the way you've been trained and the way your experience with supracondylar fractures.
And how do you all know that you've got a good reduction? Because the first step is getting a reduction. So how do you check whether your reduction is good? Anyone? So madam is, I asked them, of course. So just don't see your zones and lateral, you see your oblique views. So the column continuity, the oblique views are important. Okay, medial column, lateral column. Because sometimes otherwise in AP and lateral you cannot judge the rotation. So your column continuity or the pillar views or the oblique views are very important. Okay, and as in if you can go back to that X-ray where you had already fixed it, but suppose just said consider there are no wires. This was his reduction X-ray. You see the proximal fragment spike which is anterior to the distal fragment, the width of proximal fragment versus the distal. All that suggests that there is rotation. Okay. So always check that your rotational stability is also there before you go ahead with your fixation.
Also that your implant will never get you a reduction. You will have to reduce first and then pass the implant. If you try that, maybe once a while you get lucky, but here it is actually distracting. Yeah. So Deepak actually had to pull the wires, realign it and put it. So that is also one message, that reduce it and then fix it. Your implant is never going to get you a reduction, and that is true for almost every orthopedic case, not only for this particular case.
And the another way of looking for the stable reduction is, one is whether the reduction is acceptable or good or not. That is oblique views, and another is in lateral view the anterior humeral line should pass to the capitulum. So that is also another way of checking on X-ray.
Okay, so just quickly go through. So we have the last batch of cases.
So this is one article which we have published talking about atypical supracondylar fractures, which everyone can go through, and we talk about the tips and tricks also, how to reduce it and fix it. So the take home message is always classify the fracture properly, recognize the fracture pattern. If you don't recognize the fracture pattern properly, you are going to land up having complications, or you will have difficulty in getting the reduction properly. And always do an internal stress view after you fix the fracture. If you feel the fracture is still unstable, add a third wire or do a cross pinning. Thank you.